I think patients come in asking sometimes for non-surgical rhinoplasty, and sometimes the terminology is confusing to folks. Like, they think it's maybe liquid rhinoplasty, or, is that the same thing? Is it, what materials are used? And then, of course, the number one thing is candidacy. Like, I find that people call up asking, like, do you do this procedure? And I say, well, yeah, for the right person, and so I think determining who's a candidate, I think it's different for different providers. I think people who, like you and I, who actually do rhinoplasty surgery, we have maybe a different approach to it compared to some, doctors or nurses who may not ever operate on the nose. Kind of start things off. I mean, what's your kind of approach to people asking that question about can they use filler in the nose?
Yeah, I mean, I think you brought up a lot of good points right there. I do non-surgical rhinoplasty in my practice, not nearly as frequently as I do surgical rhinoplasty. So anytime a patient comes into my office for a consult for a non-surgical rhinoplasty, the very first thing I ask myself is, are they a good candidate? Because if they're not a good candidate for that, I'm going to offer them a surgical rhinoplasty, which happens probably 99% of the time. And I think that's a true distinction between what we do versus what happens, unfortunately, sometimes when people go in to see a practitioner who maybe isn't as comfortable doing rhinoplasty or doesn't have that capability of doing a surgical rhinoplasty. If a patient comes in and they want a non-surgical rhinoplasty, guess what? They're getting a non-surgical rhinoplasty.
Absolutely,
pretty much no matter what. Yeah. So it all comes down to trying to teach both patients and practitioners who is a good candidate for a non-surgical rhinoplasty. And in my opinion, the only patients who should ever be considered for a non-surgical rhinoplasty have a low set radix. That means their radix, which is this area up here for everyone listening, is pretty low set, and they have an under-projected tip. Okay, because the two areas that you're going to inject for non-surgical rhinoplasty are the radix and the tip, to try to disguise a dorsal hump. Now, I don't know about you, but what I far more often see in my practice are patients coming in either wanting or having already had non-surgical rhinoplasty, and they have a relatively large dorsal hump and a high set radix.
Yes.
And sometimes even an over-projecting tip. And so if you go into a practitioner that doesn't do rhinoplasty or isn't good at it, they're going to end up doing fillers on the patient.
Yeah.
And you're going to end up with a massive radix that just blends straight into the forehead and goes right down to the nose.
The Roman nose.
The Roman nose, or the Avatar nose.
Yeah.
From the movie Avatar, where it just completely obliterates the frontal nasal junction, and it really looks quite ridiculous. And what's even more concerning to me, Gary, is that I'll see people's Instagrams, mostly practitioners' Instagrams, where they will intentionally disguise that avatar look in the after photo by either having the patient in a profile view turn their head slightly more in the after shot to try to disguise that obliteration. They'll get clever and they'll only show the nose, and then they'll show different degrees of covering the nose to try to disguise that,
or the lighting is totally off, where
or
like
the lighting is totally
on
off,
the lower part, and
exactly. And then I've unfortunately had the displeasure to see several people blatantly Photoshop non-surgical rhinoplasties, where they're showing results that are just simply not possible with non-surgical rhinoplasty.
Well, that's horrible that's being done. I mean, I think you brought up an excellent point of really focusing the efforts with the filler on the midline, because that's where we kind of have some idea of the vascular anatomy, where we know it's relatively safe. I think the dorsum is safer than the tip. I think tip vasculature is a little bit harder to predict, but I think staying deep and central on the dorsum is relatively safe. And I love the point about the low radix. That's just critical. And so I personally I like injecting the dorsum. I try to avoid injecting the tip too much, but I have patients sometimes asking me for sidewall injections for little depressions, or I mean, what do you do with the scenario of someone who's had surgery before and then they want to have filler, in like kind of a post rhinoplasty? Vasculature has changed, right? So I hesitate with those, but will you fill someone who's had rhinoplasty prior surgical?
Only very hesitantly, and only a little bit. I think the thing that we have to be most cautious on, I love what you said, stay deep, stay midline, that's safe. When injecting the tip, if you are injecting the tip and you're trying to get more and more and more projection from the tip, or more refinement from the tip, you have to stop at a certain point. If you're injecting and the next spot where you're putting your needle and you keep injecting, and filler is coming out of the skin at that point, you've gone too far. And what's probably going to happen is 3 days later, they're going to get red. They're going to get little pimples coming out of their nose, and that's due to vascular compromise. It doesn't have to. What I found most interesting is, it's classically described of sort of the embolic phenomenon of when you intravascularly inject someone, you get emboli, and you get that sort of necrosis or semi-ischemic look. But it's not necessarily from embolism. It can simply be from compression.
Yes, outside.
And the thing that's most surprising to me, Gary, I don't know if you've seen this, but I've had over the years a number of patients come in the office with clear either embolic or compression ischemia that's been going on for maybe a few days to a few weeks. And it's surprising to me what the patients tell me. They tell me that their practitioners called it an allergic reaction, called it something really other than what it truly was, and sort of tried to hide it from them, which I'm very surprised to see. But I think that
I had
happens.
a nurse injector who did it to herself and had, an embolic type of event along the dorsum, and her reasoning for injecting herself was that before she injected her patients, she wanted to try it on herself, which on one hand, like, that's nice of her to do, but on the other, I'm like, please, like, I'm happy to do the injection for you and not charge you. Just don't do that to yourself. But it's kind of rough. So if someone comes in who's had filler clearly in their nose, will you dissolve it before doing surgery?
Great question. I love that question. Somewhat controversial question. I see a lot of people out there that say, inject vitreous or hyaluronidase in there before you do the surgery, which is totally fine. There's nothing wrong with that. For me, I don't. I actually just go in and operate on them. I find that because I do open rhinoplasty, it's very, very simple and easy to take the filler out. That's one thing I disagree with when some people say you have to dissolve it before surgery. You don't. Anyone who's ever done open rhinoplasty who's good at it will know it is so simple to take that filler out. And it's just, that's what's also shocking to me when I do these open rhinoplasties that have already had filler, the places that people are injecting the filler. When people are injecting straight into the columella, I just say, my God, like, I can't believe someone would inject straight into the columella. And the reason they're doing it, and the patients tell me, because I'll ask them after surgery, I'll say, you got a lot of your injections right into the columella right there. And they'll say, oh yeah, the person did it to lift my tip up and act as a columellar strut graft. And I just say, my God, that's so risky, so dangerous.
Yeah, and sometimes it's not worth it. Last filler question from my end, what is your material of choice when you are injecting for the nose?
Usually Juvederm. Yeah, usually Juvederm.
Okay.
I just have good, long-lasting, relatively long-lasting results with it. But I'm sure there's better stuff out there. What do you like?
No, my preference is I don't even carry Juvederm in the practice. I only have the Restylane line. So, Lift, Restylane, L, and Silk, and I'm able to pretty much do anything I need on the face with those three. I use Lift primarily for the nose. My only issue with Juvederm, well, in fellowship, I just found that it was attracting too much water for my taste. That what I was left with at the end of the injection wasn't exactly what I found like a week later. Just for that reason, I guess I've moved away from it. But again, it's what works best in your hands, So I literally don't carry it. So I'm sure if I used it, I'd get better at it. But I've just been using Restylane.
Yeah, it's also interesting, Gary. Just one more comment on fillers. I've had patients who clearly have either an inverted V or something some other serious problem where they have a visible step off the bony cartilaginous junction. They clearly need spreader grafts or major nasal reconstruction. I've had patients tell me that they go to practitioners who offer to inject that area, and some even claim it will improve their breathing, which makes zero sense whatsoever.
Right.
And so there's just a lot of disinformation out there about what fillers can accomplish and can't accomplish in the nose, and people have to be careful.
Yeah, for sure. No, great points, Rich. Thank you.